This video we're going to talk about some specific agents that we commonly use in the morbidly obese patient and basically how to use them. So pre-op sedation. In general, we want to avoid routine pre-medication with sedatives. Some hospitals, everybody gets oral benzos or IV benzos in the pre-op, and we don't typically do that, but a lot of people like to give some benzodiazepine pre-op. But in this patient population, you got to be very careful. And especially with people with sleep apnea, you get much more pronounced respiratory depression with benzodiazepines and opioids in the sleep apnea patients. They're particularly sensitive to drug-induced respiratory depression because of their upper airway collapsibility and decreased arousal response to airway occlusion. What about induction agents? So let's start with propofol. Cardiac output is a significant determinant of peak plasma concentration. In continuous infusion, the volume of distribution and clearance increases with increasing total body weight. Clearance and volume of distribution are similar to lean subjects when obese patients are normalized to total body weight. So, propofol maintenance infusion should be based on total body weight, and for induction of anesthesia, you got to use lean body weight to estimate dosing. For etomidate, the pharmacodynamic pharmacodynamic parameters haven't really been determined in the morbidly obese patients, and we don't really use etomidate as often anymore. It has similar PK parameters to propofol though, so for induction, probably should use lean body weight. And remember, 0.3 per kilo, that would be the reasonable dose in the patient in extremis, because if you give higher than that, you can get in trouble. For midazolam, the total volume of distribution in obese patient is about 3 times larger, and the elimination half-life is 3 times more prolonged. So there's no difference in the clearance rates. So a single IV dose of midazolam should be given based on the total body weight, but if you're running an infusion, it should be adjusted according to the lean body weight. Has significant potential to accumulation, so because it's a very fat-soluble drug, and larger initial doses are required to get the same effect. But again, you got to be careful about the accumulation. What about the neuromuscular blockers? The non-depolarizer, there are polar and hydrophilic. They're distributed poorly into excess adipose tissue, and obese individuals have larger absolute lean body mass, extra adipose tissue, decreased proportion of muscle mass, and body water. So, use ideal body weight for dosing. Succinylcholine. There is increased amount of plasma pseudocholinesterases. There is increased extracellular fluid, so administration should be based on total body weight. So for sucks, you got to use total body weight, but for the non-depolarizers, you got to use ideal body weight for dosing. But neostigmine. There's very minimal data when it comes to neostigmine, and at 25% recovery of twitch height, recovery time to adequate reversal is about 4 times slower in the obese patients. So total body weight is used to calculate the dose, but again, you still have the maximum of 5 ml for the neostigmine. So sugammadex is a more controversial thing when it comes to dosing for morbidly obese patients. It's a newer drug, of course, and the manufacturer recommends using actual body weight, even though most of the original studies use lean body mass. And when the drug was being developed, it was developed such that 200 milligrams of sugammadex was designed to neutralize 50 milligrams of rocuronium. And you may argue, what is the downside of giving too much? Well, not much, but the cost is one, and the other risk of getting a really bad anaphylactic reaction if the patient is susceptible, but that may be minimal. What about opioids? According to ASA Chloe's claim, 48% of adverse respiratory events secondary to opioids were in obese or morbidly obese patients. The morbidly obese patients are more susceptible to the upper airway obstruction and respiratory depression opioids can induce. Morphine and hydromorphone. They can be associated with drowsiness on emergence, so avoid using long-acting opioids in the peri-op period. So that's one of my pet peeves. When you have a 200-kilogram patient having a gastric sleeve procedure, you don't start with 1 milligram of hydromorphone. That's not the best approach. Fentanyl. Increased cardiac output results in lower plasma fentanyl concentration during the early distribution phase. Clearance is significantly higher in the obese patient and increases linearly with lean body weight. So it is a fairly safe drug compared to other opioids. Fentanyl administration for morbidly obese individuals should be based on lean body weight, though. If you use actual body weight, you're going to significantly overdose them. Sufentanil. It's a very highly lipophilic drug, and the obese patients have increased volume of distribution and elimination half-life for sufentanil. So use lean body weight for dosing. Remifentanil. An infusion based on lean body weight results in similar plasma concentration as normal weight people, given an infusion based on lean body weight. So use lean body weight for dosing. Dexmedetomidine. It reduces peri-op and post-op opioid requirements and also length of recovery room stay when it's used as adjunct for under general anesthesia. There's very minimal data when it comes to dosing, and most sources use adjusted body weight. Half-life is significantly increased with any hepatic dysfunction. So if the patient has, elevated INR, liver, any concerns for liver synthetic function problems, or the low albumin, which could be a marker for liver disease, be very careful about dexmedetomidine, because if you use normal dosing in the patients, they're going to be asleep for 24 hours. What about inhalation anesthetics? So 0.6 mg of isoflurane for 2 to 4 hours. Obese and non-obese subjects had similar times to recovery. There's an increased peripheral tissue uptake for isoflurane, and the long time constants together with decreased fat perfusion combines to minimize the effect of increased adipose tissue. So it doesn't really have much of an effect. When ISO is used in routine clinical practice, the effect of BMI and ISO uptake is clinically insignificant. So if you're having a regular procedure for a few hours long, you can use isoflurane. There's nothing wrong with that. Obesity is associated with glomerular hyperfiltration, and increased BMI is a risk factor for end-stage renal disease. So that raises a concern for halides, the fluoride ion that sevoflurane has. It has more fluoride than iso and desflurane. So Karash and colleagues, they did a randomized study of 55 subjects with normal renal function. They did SIVO versus ISO for 9 MAC hours at fresh gas flows of 1 liter a minute. There was no difference in post-op renal function. So desflurane, Amy's favorite drug, theoretically limited distribution into adipose tissue. Emergence and recovery is faster with des than ISO in both obese and non-obese subjects. Studies comparing des to SIVO have yielded conflicting results. And in this study of 36 patients, they looked at desflurane versus propofol versus ISO. There was faster immediate recovery, higher SpO2 in PACU admission, and improved patient mobility in PACU. Less pronounced sedation at 30 and 120 minutes afterwards. And disadvantage of desflurane persists at least for 2 hours after surgery. So there's improvement in patient mobility, reduced incidence of post-op desaturation. So if you're going to use desflurane for any patient, the morbidly obese patient, especially the ones with sleep apnea, are the best, the right patient population.